I am Nanda from 6A group. My topic of self-work is levels of evidence and grade of treatment. First, we can look at evidence-based medicine pyramid. Its topmost component is meta-analysis. We can discuss each of its components. First one is cohort study. It is a forward study. In this study, we can select a course and can do research on that course for 15 to 20 years and find out the effect of that course in that population. For example, we can select cigarette smoking as course and can do research on a group of smokers for 20 years and find out effect of smoking on that group of people. The effect we consider is lung cancer. Next component is case control study. It is a backward study. Here we can select an outcome and find out the cause. For example, we can select a group of lung cancer patients and ask them whether they are smokers for the last 20 years. Next one is retrospective cohort. It is a forward study. In this, we can select a course and find out the effect in present time. For example, we can select a group of smokers in 2010 and find out how many of them developing lung cancer in 2020. Next one is meta-analysis. It is known as the analysis of analysis and it is the gold standard of evidence-based medicine. Next one is randomized controlled trials. It is the studies that measure the effectiveness of a new intervention or treatment. Next, we can discuss about grade of treatment. In this, the author decide a clinical question with two or more alternatives and the outcomes that matter. Ideally, a systemic review provides the best estimate of the effect size for each outcome. The authors then rate the quality of evidence which is best applied to each outcome. Grade has 4 levels of evidence: very low, low, moderate and high. Very low grade. The true effect is probably markedly different from the estimated effect. Low grade. The true effect might be markedly different from the estimated effect. Moderate grade. The authors believe that the true effect is probably close to the estimated effect. And the high grade is the authors have a lot of confidence that the true effect is similar to the estimated effect. Let's discuss grades of treatment with example. Treatment of hypothyroidism with levothyroxine therapy. Grade 1A is levothyroxine monotherapy considered to be the standard of care for hypothyroidism. Recommendation. Levothyroxine is commented as the preparation of choice for the treatment of hypothyroidism due to its efficacy in resolving the symptoms of hypothyroidism, long-term experience of its benefits, favorable side effect profile, ease of administration, good intestinal absorption, long serum half-life and low cost. Strong recommendation, moderate quality. Grade 1B. What are the clinical and biochemical goals for levothyroxine replacement in primary hypothyroidism? Recommendation. Levothyroxine replacement therapy has 3 main goals. These are to provide resolution of the patient's symptoms and hypothyroid signs, including biological and physiological markers of hypothyroidism, to achieve normalization of serum thyrotrophin with improvement in thyroid hormone concentration and to avoid overtreatment, especially in the elderly. Strong recommendation, moderate quality evidence. Grade 1C are clinical parameters such as cold sensitivity and dry skin useful by themselves for assessing adequacy of levothyroxine replacement in primary hypothyroidism. Recommendation. Although it may be helpful to follow changes in clinical symptoms longitudinally in patients treated for hypothyroidism, symptoms alone lack sensitivity and specificity and therefore are not recommended for judging adequacy of replacement in the absence of biochemical assessment. Therefore, symptoms should be followed but considered in the context of serum thyrotropin values, relevant comorbidities, and other potential causes. Grade 1D are tissue markers of thyroid hormone action helpful in determining the adequacy of levothyroxine replacement in primary hypothyroidism. Recommendation. Tissue biomarkers of thyroid hormone action are not recommended for routine clinical use. Outside of the research setting, since these parameters are not sensitive, specific, readily available, or standardized. Weak recommendation, low quality evidence.